Thank you. Now I'm recording. Um, okay. So what I'll do again, um, thank you. No, that's your job, Michaela. You guys are supposed to remind, I should know. So no, I will open the test on Monday at class time. So we won't do a review during our class. The test will be open. So what I was looking for, as far as on the attendance questions, was why we worry about bloating. You're going to see that on the left side because the rumen occupies the left side of the abdomen. So we're more likely to see a swelling on that side. And that's one of the reasons that laying a cow down for anesthesia is risky, is because what can happen is rumen contents can trap in the esophagus and then they can't burp. Or if they block the other way, they can't pass gas, and that's what causes the bloating. Because remember, rumen contents are going to continue to produce gas while they're asleep. So we don't want that building up. So you want to check the left side of the abdomen. And bovines produce more saliva. So the answer to that was due to their anatomy and due to their digestive system, they need a lot of saliva. So they do produce excess amounts. But what I said in the video, if you watch the videos, I don't always pre-treat them with atropine, because what will happen when you give atropine to an animal that has a lot of saliva, sometimes it can dry up their inner secretions and then it makes them very sticky. And if you have to suction them, I'd much rather have a lot of saliva that is loose than to have this really sticky saliva that I can't suction out of the airway. So, and another reason is we don't want to affect their gut motility. So it's not, atropine is not used routinely in a cow for those two reasons. But again, if it's an emergency and their heart rate is dropping, you would definitely want to, you'd have to give atropine in an emergency. But we don't use it as a precautionary pre-med. Why do we perform standing chemical restraint on bovines? And it says, why should we not lay them down? One of the reasons that they're good for standing restraint or standing chemical restraint is, first of all, their temperament. So they're very relaxed. So they tend to be easier to handle, easier to work with. So that makes it simple. The other thing is, again, we don't want to lay them down and potentially compress the rumen and cause bloating. Now, some people put me because they produce excess saliva. We can intubate and we can suction them, so that's not a reason. Myopathy and neuropathy are a concern, but that wouldn't be a reason. If you have to operate, you have to operate. But the other two reasons of the excess saliva and the fact that a lot of times you can do procedures standing with them that you couldn't necessarily do in a horse. Now, they are not prone to colic, so I don't usually worry about colic in a cow. That's more of a horse thing. But you do worry about the saliva, you worry about aspiration, you worry about bloating. But you can control the saliva by suction and getting them intubated quickly. They are done by a bolus technique, so you got to get them down quick. And then it said, question 4, is intubating the same as horses? Some confusion here. Some people said, yes, it's blind. Now, both the adult cow and the adult horse are blind, but differently. In a horse, they are in lateral recumbency. You pull their tongue and you literally slide the tube in. In an adult cow, in the video I explained, you want to have them sternal, and you can't see back there. You would put your hand and you would guide your hand and put the tube, you would feel the larynx. So it is blind where you don't see it, but they need to be in sternal, and it is blind by feel versus just completely blind. And then, you're going to inflate the cuff. We often pull the tube with the cuff inflated because they have all that excess saliva, and we want them to be able to, we want to pull out some of that saliva. Sorry, I'm trying to find something I had in my bag, and I can't find it right now. And I threw it in here. Okay. No, darn it. Okay. So those are the questions. Hopefully that if you understand, because I'm not putting feedback on these questions. I'm just waiting till everybody's done and give you feedback when we review. The other thing I want to stress that I did talk about in the video is that they're extremely sensitive to xylazine. So for example, if I had an 1,800-pound horse and an 1,800-pound cow, if the dose in a horse was 1 ml, a cow is going to get 0.1 mLs. They're going to get a tenth of the dose. So they're extremely sensitive to the effects. So just because they weigh the same, they respond to xylazine differently. Now, that is why when I talked about induction protocols in the cow, it's called double drip. So what they're doing now in the horse, it's xylazine, ketamine, guaifenesin. In the cow, it's ketamine and guaifenesin. They may or may not use an opioid, or they may use a very, very tiny amount of xylazine. But the reason it's double drip is because the cow is more sensitive to xylazine. Okay, extremely sensitive. And then we use a lot of local blocks, the inverted L. And then in swine, the protocol in the notes that I told you, and I guess I could type it here since we're live. I tried to type it in the video just in case you could see it. So we use a combination in swine called TKX, which is Tilazol, ketamine, xylazine. I've always taught you that I don't usually use 2 drugs from the same category. Like you pick it's like a recipe. Pick a spice, okay? I'm going to pick an opioid, I'm going to pick a sedative, and then I may or may not pick an anticholinergic. In this case, in the pig, you're using tilazol and ketamine. Both are in the dissociative family, so you are using 2 of the same drug, but in that protocol, it's very good for mobilization. So a pig, you really want to observe from afar. You really want to we have to be kind of cautious handling them. Not that they're dangerous, but once you grab a pig, they're going to start screaming. And one thing that you guys can realize is that if you want to get a respiratory rate, you can watch and look. You don't even have to touch them. Now, eventually, you want to listen to their chest, but if you just need a respiratory rate, you can watch that from afar. I mean, I do that in cats, I do that in dogs, especially if you have an aggressive patient that, when we're going to grab a pig, they're just screaming and they don't like to be restrained. So once the doctor says, we're ready to go, we're not going to double our work. We're going to do a visual assessment, whatever we can get. And then once they're down, we can listen to the lungs. We can listen to the heart. We can do, if we have to draw blood, most of the times you do want that information before you do anesthesia, but they make it challenging. Like when I talk about exotics, that's what we're going to do next. A bird is very stressed. And so I'm not going to get out a bird to do a physical, stress it out, put it back, and then the doctor's going to come in, get the bird, pull it out, put it back. All right. So in a bird, we're going to kind of do everything at once. And a lot of a bird assessment, I just look at them in their cage, look at their eyes, look at their feathers. Like if they're like a bird is ruffled, then that's a sign sometimes that they're sick. So like a pig, look at their eyes, look at their snout. Sometimes they open their mouth and you can catch like their color. Watch them breathe. Do they have extra effort? Is there a bunch of diarrhea in their pen? You know, like I always try to have exotics people bring the cage because I can look at the droppings, I can look at the bedding, I can look at how the cage is, and that could give me a clue to is there anything wrong with them? Okay. Did anyone have a question off the bat over the study guide or, you know, anything from the discussion board that didn't make sense? Let me try to pull up. The problem is, well, you know what I can do? I can pull up somebody's homework. I don't have the digital copy of my nope. Let me try to get to my, oh, okay. So for venipuncture, yes, if we need to draw blood, you're usually going to draw it from the ear vein. So there's an auricular, auricular. So let me type that here. Okay, so the ear vein, now you can hit the jugular on a pig. The difference on that is it's a blind technique, and what you do is like you find the point of the scapula and you put you actually go in at a 90-degree angle. You know, normally you guys go with the jugular, but you're actually, and I'm sorry, it's not the jugular. We're doing it from the, I want to say it's the brachial vein. But what I want you guys to know, most of the time you're going to use the ear vein because sometimes you can see a lower medial cephalic, but their legs are so thick with fat and the skin is so tough. So it makes it very challenging for blood draws. It said when assessing depth, what specifics do we talk about? So in the pig, it was mentioned that their eyes are not reliable. So you want your jaw tone is going to be a better sense of depth. I mean, obviously heart rate, it usually goes up when they're light and down when they're deep. Respiration, up when they're light, down when they're deep. And then, you know, normally I told you eye positions rotate ventral when they first go to sleep and central, and you look for a blink, but their eyes don't move as much. They don't assess much of a blink. So you're going to go with your jaw tone and your physical parameters, like your heart rate, your respiratory rate. I mean, you can also pinch in between their toes and also check for a withdrawal reflex, but your eyes aren't a reliable indicator. So hopefully that answers that question. Excuse me. Also, I talked about the thick needle or long needle, at least a 1.5-inch needle, probably going to be a 20 gauge or an 18 gauge because you have to think about what are footballs made out of? Pigskin? They're pretty thick. So like when we give cows and when we give pigs injections, these little 22 gauge needles are just going to hit the skin and bend. So you're going to need longer needles, especially for swine, due to their thick sub-Q fat. Like I said, the next time you go home and somebody's making an Easter ham, if it's got the skin, you can see how much fat is in between the skin. It's part of what I love ham. Part of what makes ham good. But if you're giving an injection, you need a bigger needle you need a thicker needle, at least a 20 gauge, if not an 18 gauge. And remember, the lateral neck, I talked about the base of the ear, there's the point of the shoulder, and it makes almost like a triangle. If you go to the back of the neck is the long part of the triangle, and point, anywhere in here. So the jugular and carotid are a little more down here. So if you go up more in the dorsal part of that triangle, the lateral neck muscles, because it's not a prime cut of meat. You don't want to use the gluteals. You don't want to use the back muscles because, again, those are prime cuts. Now, like I said, if it's like a potbelly pig that's a pet, that's different. But if you're working with at a farm and those pigs are eventually going to go to slaughter, we don't want to damage the muscle with injections in those prime locations. Talked about malignant hyperthermia in the notes. The other thing to mention in these guys, oh gosh, can you still see me? My computer's freezing up. Quick induction, intubation in a calf is a stylet technique. But in the adult, it's by feel. You don't use but they are prone to laryngospasm. So both of them you would spray with the lidocaine so they don't spasm. Suction to suction out. Oh, and I sent you guys, now this doesn't necessarily apply to bovine, but I want to make sure everybody understands this. And I sent you guys an email. I had several people on the equine homework. I asked a question about what is the difference between invasive blood pressure and non-invasive blood pressure. And invasive blood pressure is going into an artery. When you measure blood pressure, it's always an artery. So I had people, because I said invasive is a catheter in an artery. And then I said, tell me arteries you would use. I had people tell me jugular. There's no jugular artery. There's a carotid artery. We wouldn't use that. We use peripheral arteries. Transverse facial, mandibular, and dorsal pedal are the most common. But I don't know why people were giving me names of veins. These are arteries. Blood pressure is always in an artery. And if it's invasive blood pressure, which is also called direct blood pressure, you're going directly in an artery. But people that put their answer put literally the same sentence, like it came from somewhere. Or people are doing homework together and writing the same answer. Because I don't know where that came from. So if you got that answer, if you put that answer, someone needs to communicate with me and tell me where they found that, why they put that. There is something called central venous pressure, and that is a jugular catheter, but that is not measuring blood pressure. That's measuring pressure within the venous system for fluid therapy. It is not used to measure arterial blood pressure, which is what we're worried about during anesthesia. Okay? So let me answer Michaela's question. What's the difference between the curved and a straight stylet? It's just going to depend on what you have. The pig, like people, has a natural kind of curve. Their trachea kind of curves. And so the curve to the stylet would, most endotracheal tubes are curved. So the stylet would just fit in that curve. But you can use a straight stylet because dog, cat, cow are all going to use a straight stylet. It's just, it may be more beneficial for the stylet to have a curve versus using a straight. Okay. Does that answer your question, Michaela? Hopefully. Okay, now this is weird because I can see names and I know people are here. Okay, most people are off. So one concern, and I honestly, it's not my goal to continue to harp. It's not my goal. I know this is a stressful semester, and I know this is not how anybody wanted this to go, but it is the situation that you are in. The one concern I am having is I often write a 3-part question, and I will have people answer one part. So put yourself in my shoes. Did that mean you don't know the answer to the other 2 parts of the question? Or did you just look at the last part of the question and didn't read the details and finish answering the question? My concern is following directions when you're in surgery. You have to be able to read the whole protocol and follow every step and be very detailed. So when people take shortcuts on homework, my concern is that going to translate to shortcuts in surgery. Okay? My other concern, and I know everybody's kind of here, and if you're driving, I'm putting my hands up to the top of my head because everybody is overwhelmed and frustrated. But I know that in radiology, I'm in an office with Mrs. Long and Mrs. Zuber, is that the anesthetists are coming in unprepared. They don't either know their values. You don't understand the drugs that you're using. You don't even know what they're doing. And I think I made it pretty clear. If you're an anesthetist, it's your duty the night before to prepare. Everybody can make a little note card and write down dexdomitor, butorphanol, atropine. Why are you giving those drugs? What are the common side effects? You literally do not need to write a novel. You can put 2 or 3 bullet points. Opioids are for analgesia. They do enhance sedation, but dexdomitor is your sedative. So you give dexdomitor because you're sedating, but it does have a little analgesia. You're giving butorphanol because it's an analgesic, but it has a little, remember I said the reason you use them together is they're synergistic. They work together. Butorphanol is going to work better with dexdomitor, and dexdomitor is going to work better with butorphanol. Now, why am I giving atropine? Why is atropine even on a list for these dogs? And why would I be concerned about the heart rate? Why? Which drug are you giving that causes bradycardia? Dex. Dex, thank you. So, and you remember what I told you, dexdomitor causes massive peripheral vasoconstriction. So what happens is blood pressure naturally goes up. The heart rate is going to come down. It's a protective reflex bradycardia. Now, whether you give atropine is up to your doctor. I don't typically give atropine. I monitor the patient, and if they're okay, the anesthesiologist, his opinion was don't give atropine. If you're getting in danger with bradycardia, you can reverse the dexdomitor, but they are supposed to be bradycardic. But do you see what I'm saying? In a protocol, and I haven't had you guys memorize a ton of protocols. I've told you kitty magic. I've told you triple drip, double drip. Each drug in that protocol has a primary job. It sometimes does a little side thing, but every drug in a protocol has a job. There is a reason you are giving that drug. If you are an anesthetist, it is your job to know why you are giving that drug. Because remember, I told you guys, if you anesthetize a dog and you get a heart rate of 40, you better have given an alpha 2, because if you have not used an alpha 2, that's highly abnormal. Yes, Marissa, I got your email. Sorry. You're fine. Okay. You need to know that. and I don't say panic, but what I'm saying is if I get a heart rate of 40 and I go, oh wow, I gave dextrometor, okay, it's low. If I have a heart rate of 40 and I used ACE and buprenorphine, I'm like, why is my heart rate 40? Do you see what I'm trying to say? There is a reason that it is so low with dextrometor. But what you have to do as an anesthetist, and I've tried to impress this upon you, is that the night before you have a list of drugs and you know what you're using, make yourself a little note card with any alpha 2. Correct. Joss or Joycelyn, if you use xylazine, if you use dextrometor, they're going to both be bradycardic. Alpha 2s cause bradycardia. Okay. So what I want you to do, if you're the anesthetist next week, okay, I want you to make yourself a little note card, and I want you to put a few effects of the drugs. You have my notes. You have your drug project, okay? You have Plum. Because you're going to get quizzed. Our job at school is to quiz you. Nobody is trying to be mean. Nobody is trying to make you stressed. Okay, that's not the goal. The goal is if I quiz you, then you know where you are weak. If I quiz you, you know what I expect of you. So when they are asking you questions in radiology, the goal is to get you thinking on how an anesthetist should be thinking. Because ultimately, it's your responsibility to be like, is this dog okay? Is this cat okay? Is this normal? So what I've tried to teach you is, here are parameters, here are drugs, this is what I see, this is what I shouldn't see. Okay? But I can tell you, every time I've done anesthesia, especially if I've had a really bad case at Purdue, I was reading the night before. I was looking in my textbooks. I was looking up journal articles. That's being prepared. Now, if I quiz you and you go, oh, that's that drug and it caused, hang on, I have my card. I have no issue with that. Okay? You wrote it down. You were prepared. I'm not expecting everybody to spit this stuff off the top of their head, but you should have some idea of what you're doing. If you have no idea of why you're giving drugs, or you don't know the family they belong to by now, you need to prepare better. Again, it's week 5. So in about 4 weeks, you're going to be doing this for surgery. 4 weeks. I can help you. I can meet with you. I met with some people about the machine. I'm going to try to figure out a day we can be together so I can go through some stuff about surgery with you. But then the preparedness is on your own. So it's a little disconcerting for me to hear them mention unpreparedness, because I've told you that was an expectation. Okay? Are there any issues? Does anybody want to say anything? Nobody's saying anything. Well, I mean, some people are typing stuff. This is open period to talk. I mean, I'm also here to listen. Because you're right. I mean, mom talks always come from the heart. And you guys know that I care deeply about your success. And yes, we can, Miranda. Well, Melissa, you said, is there a way to get drugs to write down? Well, in radiology, I'm glad they're helping. That's the point of these talks, is to hopefully motivate you and snap you into a reality. Melissa, you're going to get a list of drug protocols, and those are the ones you'll want to write down. So like in surgery, you guys will get a protocol list. I'm going to give you a copy. And then Joycelyn, I think you're right. Zuber sent you a list of the drugs. So what I want you to do is just whatever drugs you're using, like Melissa, say for example, you have a cat that day and you're using Kitty Magic. Well, you know, Kitty Magic on your protocol is ketamine, dexdomitor, and butorphanol, and then you're going to go on to isoflurane. So that'll be on your protocol. So you'll know a couple nights in advance if you're the anesthetist on a cat or a dog, and you're going to have a protocol sheet. Does that make sense? So I don't really need to write the list down. It's going to have a list. Melissa, does that make sense? So like I said, you guys don't need to write up, like you don't need to write up morphine. You don't need to write up hydromorphone or fentanyl. You're not using those drugs. You need to use those for the board exam. But when you go into surgery, I just want you to write down the drugs you're using in surgery, which will be on your protocol packet. And then if you're going in there, yes, and Caitlin, the drugs are on you're going to get, I think I have one with me. Hang on. I'll show you real quick what I'm talking about. Well, of course, I saw it in my bag, and now that I'm going to grab it. Okay. This might be hard to see, but it's a sheet, and it's going to list all the drugs, the fluid rates, the bag sizes, the flow rates, okay? And this is a canine. So if you have a canine spay, I would look up atropine, Serenia, dexdomitor, propofol, okay? And then if you have a cat, this is going to be a different list. So they have a dog list and they have a cat list. But like I said, you normally know a couple days in advance whether you're going to have a dog or a cat patient. And then I would just, like I said, a day or two the night before, write up the drugs that, AJ, hey, what do you have? AJ, oh my gosh, sorry. He's chewing something. You are going to write up the drugs. So hopefully, I don't know if she went away, Melissa. But so it's not like I said, you're going to have the drug sheet, and then I would go home the night or two before your anesthetist, and I would just, okay. So you'll know the drugs that you need to know. You'll know if you're a dog or a cat. The only big difference is I think in the dogs you guys are using butorphanol, and the cats you're using buprenorphine. Otherwise, propofol is the same for both species. Well, the same effects of the drug, different dose. And like I said, right now in radiology, you're using butorphanol if it's a dog, buprenorphine if it's a cat, dexdomitor, and atropine. So all you have to do the night before your anesthetist is read up on those 3 drugs. Also, okay, thank you, Katie Pollock. When we did monitoring, I sent you guys, I remember in my PowerPoint, it talks about normals, like we were talking about working up an awake patient, but then in monitoring, I sent you an extra PDF. It was like an 8-page PDF, and it talked about cardiovascular monitoring, respiratory monitoring. It was like a separate handout. And I said, those are the normals you needed to know for the test. So if you need to know normals for your patient, it was in that handout that I sent out when we did monitoring. AJ, stop. AJ, come here. Come here. Sorry, you're being, come say hi super fast. Come here. No, AJ, come here, look. Okay, he won't come here. Yeah, and Melissa, it'll take time. Like you get to be anesthetist, I believe, twice. So, definitely the first time will probably be a little challenging. Hopefully you pick up on where you were weak, where you need to review. And then the second time you do it, they kind of try to back off a little bit. You're going to have help in there. So I'm not like you're just being left alone. People are going to be there to supervise you. So hopefully the second time through, it's going to make more sense. So you get 2 rounds through. But as an anesthetist, that's kind of the advice I gave you, like when you guys go into externship, find out what drugs you're using in your externship. And then whatever drugs you're using on externship, those are the ones you need to review. Because like I said, you need to understand all the drugs for the board exam, but clinically, you're going to be working with a certain group of drugs. Like I said, at Purdue, I mostly used ACE, morphine, pentothal, sometimes Ketval. Now, I had other patients that sometimes got special drugs, but the majority of the everyday patient got a certain protocol. And you start to get comfortable with it. So, like I said, it's not like you're going to be changing drugs every day, using 500 different things. You're going to get used to this, like, my doctor always uses this, this, or this. Okay. I just want people to be more prepared, to have an idea, because then you're going to be more comfortable with your patient. The more you understand before it's a stressful situation. So the better prepared you are when you're in there. And like I said, the goal of quizzing you is not to increase anxiety, but we have to kind of I got to get you in a mindset of when I'm verbally telling you things, that's what's going on in my head. As an anesthetist, I start what's this, Now, obviously, I've built this up over a long time, but every time I worked on a case, it built. My mental database built to be better with each case. And yours will build too, but you have to have a foundation. If you don't read anything or don't look at anything and you walk in blind and you start having problems with your patient, it's not going to go well, okay? So if you need to talk to me about something, if you need to set up a time, yeah, you guys will get there. I understand we haven't had a lot of opportunity to practice, but again, some of it can be done on your own. Like I said, make a little card, just a few little hints about the drugs and stick it in your pocket. So when you're the anesthetist, you can pull it out and say, oh, yeah, there's nothing wrong. You can do this. There's not a rule, unless you were taking a test. But if you are in surgery, we like when students have a little reference because it shows me you were thinking about it. You were preparing, conscientious. That's what I want to see. Yes. If you want to add, Katie, to your nerd book for radiology, add your normals for the dog and cat. And then, again, I would only write up the drugs that you're going to be using. But like I said, I'm going to give you a copy. You guys are going to get a surgery packet when you're a student, but I have copies of the drug sheet. And towards, I think, the last week of anesthesia, we're going to go through and practice some calculations. We're going to talk about machines, and I'm going to talk about the flow. I have a little pre-op checklist, intra-op, post. Okay, so for surgical nursing, you already have it. That's good. But we're going to go through what I have a little checklist that says, if I'm pre-op, what do I need to be thinking? If I'm intra-op, what am I thinking? If I'm post-op, as an anesthetist, what are my jobs? And I give that to you usually, like I said, the week before, and we'll talk about it. Okay, what? AJ! Oh, how did you get that? I'm gonna beat your Come here. Well, there was a bag of, he hasn't opened it, but there was a bag with a coffee can in it that we took on vacation and some granola bars. Puppy. I'm exhausted. And I'm sorry, I'm getting, after this, and hopefully he takes a nap, and I got to dive into the rest of these midterms. Yeah, AJ, look. Maybe he'll come here. Come here. Come say hi real fast. AJ, look. AJ, come here. Oh, I got both. Come here. Come say hi real fast. Oh my God. 32 pounds. Oh. Say hi. You need a puppy smile for the end of the lecture. I'm a monster now. He's a monster. Look at these paws. Look at these paws. Wait, Dad. You say hi. Don't end my lecture. Now he wants a tortilla chip. Show him how big you are. Okay. AJ, you bad boy. Okay. I gave you one tortilla chip because you were good and came here for me. Come here, baby. Baby. Come on. Mommy's got to go. Get in lecture. There you go. Okay. Sorry. Yes, he's humongous. He is 32 pounds. He's 16 weeks, so he's 4 months, and Bo is 65 pounds. So at 4 months, he's half the size of Bo and almost as tall. So I think he's going to be a little monster. Okay. Hopefully I've answered questions. I will pause and record this. If you don't understand something about the bovine and you need to meet with me on Monday, I'm actually going to be at school. I have to meet with an anatomy student. Yeah, Brianna, I'm going to what I'll do is re-email you guys I'm going to try and find that handout with the normals, if that'll help. I can try and resend it. Since I know I'm almost done here. Normals, anesthesia. Okay. Yes, if you printed it, I will. Sorry, he's like destroying something. I can try and resend that, Brianna, if that's okay. Okay. What I was going to say, if you need something on Monday, since I'm not Zooming with you, I'm actually staying at school because I have to meet with an anatomy student at, I think, like 2 o'clock. So if you need something, email me. Tomorrow, my son's graduation party and family's going to be in town. But I'm going to resend it to all of you, Miranda. Yeah, I'm going to send it to everybody. I'll just resend that handout. But it goes through, like, it's got the normals. Just email me if you need me, but Saturday I'll be a little indisposed. But Monday it'll go live at 2:20, but you'll still have till Tuesday to do it. Okay? And then we're doing exotics next. I wrote for fluids. I don't remember, Caitlin, what I wrote for fluids. I don't remember which one that is. I don't know which one. Yeah. Hey, all of those extra handouts I send are just hopefully for you guys to, like print and for like extra. Yeah. Caitlin, when you see me again, just show it to me. Okay. Why is there a sock up here? Okay. All right. Well, I will let you guys go. I got to go beat a puppy. Just kidding. All right. You guys have a good weekend. Yes, Miranda, that will be fine. Bye. Bye, Jocelyn. Oh, sorry. I'm starving. I haven't had a chance to eat yet. All right. Yeah. Sunday I'll get some rest. I have to massively clean and set up for a mini graduation party. So now I'm going to grade, clean, shop, set up, eat, crash. All right. Have a good weekend. I'm going to try. I have plenty of time to take care of myself when my baby leaves me. I'm going to be an empty nester. I say.